All right, thank you very much. Right, so yeah, this is making psychiatry moral again, role of psychiatry in patient moral development. This is work that I've done in collaboration with Matthew Broome and Julian Savulescu, and it has since been published in the Journal of Medical Ethics. So, sorry, it's always a little bit boring to discuss papers that have already been published, but I've actually always been a little bit unsatisfied with it. And as I was preparing to give the talk, I was like, oh, yeah, I don't think I'll do this the same way as I did in the paper. So maybe I'll revisit it and discussion about it won't be completely futile. So this work was inspired by this editorial that Hannah Pickard wrote with the late Steve Pearce. This is in the British Journal of Psychiatry, 2009. So what, 13 years ago now. The moral content of psychiatric treatment. And in this editorial, they argue that psychiatric treatment can enhance human morality and that good psychiatric practice demands an honest appraisal of its moral dimension. So they recognize that people have different values, but that this doesn't warrant a retreat into some kind of blanket moral relativism, and that, and it doesn't license a kind of a blindness to the moral content of psychiatric practice. And they suggest that avoiding engaging in this topic is itself immoral, because a failure to think seriously about these things will invite psychiatric abuses of power. So they think we need to, so they argue we need to face the hard questions about the role of morality within psychiatry. So we were using this in teaching a bit. I think maybe even Rivka might have been exposed to that editorial, can't remember. And I was taken by some of the strong reactions that it would get from some of the students, and I started digging around to see if there'd been any kind of rebuttals of it or engagements to take up this task that they were suggesting. And maybe I was looking in the wrong places, but I couldn't really find anything. So I was curious about that, and so I wanted to try and think of exactly why psychiatrists might be avoiding these hard questions. I basically agreed with the editorial, so I was also looking to put together some arguments to, 13 years later, let's kind of try and invigorate this this movement, these ideas again, and see if we can get some discussion happening. And I came up with we came up with a practical solution to try and help psychiatrists ethically support patient moral growth. So to kind of overcome this conflict between reasons against and reasons for. So this is the claim that we argue for in the paper. And that is that the default approach that psychiatrists should take should be procedural, whereby patients are helped to express their own moral beliefs. But in a subset of cases where the patient's moral beliefs are sufficiently distorted or sufficiently underdeveloped, in those cases, then a psychiatrist can move to a substantive approach where they try to shape the content of those beliefs. But at all times, this should be governed by the moral growth being relevant to psychiatric outcomes. So there's still some kind of barriers to just willy-nilly psychiatric involvement in people's moral views. So I take it, these points here more or less cover the case against intervention in patient morality. So treating morality, you might think is a coercive misuse of psychiatry, and that psychiatry should treat disorder and not deviance. So this can come in a bioreductive flavor if you think that psychiatry should be a kind of value neutral endeavor that fixes brains or something. Obviously that's not very popular at the moment, it has some serious problems. But you could take a more mainstream view and accept that mental illness or mental disorder has a normative component, but still say, well, that normative component is not a moral normative component, and so you can still treat disorder without treating deviance if unusual moralities are deviance. The concern here, I think, is that if we allow psychiatrists to explicitly address patient morality, then that's just going to medicalize a really wide range of behavior. And so that's massively going to increase the potential for social control of psychiatrists to exert social control, or the state co-opting psychiatry to exert social control. And the classic example when people talk about this stuff is the Soviet Union example, where opposition to the socio-political system was seen as a symptom of schizophrenia, justifying incarceration. I assume that's not what Hannah Pickard was going for, but you can see that that is probably a slippery slope argument to get you to that position. Another concern, this is in some sense a similar concern, but coming from a different perspective. So misuse of psychiatry is probably grounded in ideas about what psychiatry should do, what are the appropriate goals of psychiatry. But then you might also come from a principalist approach. You might say, what are the ethical principles guiding medical practice? Well, this also seems to go against those. So if treatment should be in the patient's best interests and consented to, that doesn't really seem to align with asking patients to meet various moral standards, because if moral standards are how patients should interact with others or what they owe others, well, that seems to be imposing other people's demands on the patient. That doesn't, is that what we should be doing with medical practice? And of course, there are some exceptions. You'd have that, someone kind of bringing this objection would have to admit, yes, it's worth using psychiatry, or psychiatry should be used if a person poses sufficient risk to other people that we might think it's justified to section that person. But you say, well, that's not because they're morally wrong, or there's something, you're not concerned with changing the moral views of that patient. It's just a risk management, harm reduction strategy, you might argue. More of a practical problem with number 3 here. So psychiatrists presumably don't have exceptional insight into moral truth. So it would seem wrong, or at least dangerous, for them to be imposing their view of morality on patients. Perhaps an extreme version of that is a relativist account where there is no such thing as moral truth. Maybe it's culturally defined, and then that seems even worse, that psychiatrists would be imposing kind of social fashions upon patients. In an earlier version of this paper, I tried to create an argument that would work even in a relativist context, where you might say, oh, well, even if moral truth is relative in that sense, it might still be suitable for a psychiatrist to help a patient meet those moral standards, because it would help them fit in. But there was a reviewer who didn't like it, and it was taking too many words, so it got discarded. I don't know if anyone would be interested in taking that up, because there is a concern that psychiatrists are implicit moral relativists. I don't know if that's true, but Hannah Pickard also kind of mentions that concern. There might be a kind of relativism that is making psychiatrists nervous about dealing with patient morality. 4, another practical concern: if you challenge patients' morality, their moral views, that's going to risk undermining the therapeutic relationship. The patient's going to be less likely to share morally charged information relevant to diagnosis and treatment if they're worried that they're going to be morally condemned for what they say. And given the importance that people attach to their moral beliefs, patients will tend to react oppositionally if the psychiatrist challenges them on their beliefs. So that's going to be self-defeating. Okay, well, that all kind of doesn't sound great then for engaging with patients' morality. So what would motivate us to go down this path? So it seems that moral norm breaking is related to mental disorder in a variety of ways. Not all mental disorders, not all instances of particular kinds of mental disorders, but there are a variety of cases where it does seem to be relevant. So some kinds of mental disorders seem to be partly defined by dispositions that make moral norm following difficult. So borderline personality disorder can involve frustration and impulsivity. Antisocial personality disorder can involve lying and violence. Some paraphilic disorders are defined by sexual desires that risk harm to non-consenting others, notably children. So it seems there's some way that moral norm breaking is constitutively related to some mental disorders. But it also looks like moral norm breaking can causally contribute to the etiology of some instances of some kinds of mental disorders. So in the case of addiction, someone might lie and steal to feed their addiction, and then feeling shame after having done that, they may then use drugs to kind of, as some kind of escapism. You can see how that would form a kind of a spiral that could feed the addiction itself. Same thing something analogous could be said for depression. If you feel unable to meet your obligations to other people because you're so depressed, but then you feel more depressed because you've failed to meet your obligations to people, then again, you could get a kind of a causal spiral there. And maybe a bit more controversially, unless, I mean, maybe that was already controversial enough. I know some people think it is. I think sometimes moral norm breaking is a symptom of mental disorder, and this is obviously rare. It's not the case that having a mental disorder makes you violent, or even necessarily more violent than just a random person we picked up off the street. But there are cases where someone with paranoid schizophrenia becomes violent when they're psychotic. And even though that could be treated effectively with antipsychotics, sometimes patients are ambivalent about taking them. And so the risk of future moral norm breaking becomes a psychiatric concern. So in these cases of where morality is related to mental disorder, it seems that treatment would be effective if it helps support moral agency, at least in these cases. So pharmacotherapy, well, methadone could be used to reduce cravings, and so that could help someone limit the situations where they might want to steal to feed an addiction, and so that can help them as they pursue their recovery, help their moral norm following as they pursue their recovery. Antidepressants sometimes can help people feel more able to meet their obligations to others, so you can potentially try and prevent that negative spiral that I was talking about. And pharmacotherapy, this is the case that Hannah Pickard discusses quite a lot in the editorial. She argues that guided reflection on experience and one's past actions can help one develop moral capacities and emotions. So I'll give you the example that we slightly elaborated in our paper. That comes from her editorial. So a man has been under psychiatric care for depression and alcohol misuse following police involvement when he harassed his ex-girlfriend. He had become preoccupied with the idea that his former partner was unfaithful to him. These ideas are of non-delusional intensity, and he's been referred to therapy because of the anger and jealousy he feels towards his ex-partner, but regards his violent outburst towards her as justified and inconsequential. During therapy, he reflects upon his childhood experience of his own father's angry outbursts, and thereby becomes aware that his own outbursts are negatively affecting his young son. He begins to empathically identify with his son, and thus developing his capacity to act morally around his son. His new beliefs about his son's experience also form the basis for a new moral motivation to treat his son better. Obviously, this new capacity, or this burgeoning capacity, and this new motive is, you wouldn't say that it's necessarily going to guarantee some transformation, but it's just about if you can increase the moral norm following in those contexts, then that might be beneficial for this patient. We can expand the net a little bit wider here without, we don't necessarily want to be talking only about mental disorder. A lot of people now think, obviously, that psychiatry should go beyond treating mental disorder, and we should be helping people to flourish. A person flourishes to the extent they live a good life, roughly, and we can have a subjective and an objective version of this. So, a subjective view, each individual defines their own idea of a good life, but as it happens, nearly everyone does place some value on morality. and believes themselves to be essentially moral. Most objective accounts of flourishing require some degree of morality to flourish. So if flourishing involves morality and psychiatrists should help people flourish, then that would suggest that where possible, psychiatric technologies, techniques should be used to help enhance people's moral agency. People know examples of this. I'd be keen to hear of some more examples. I've found, I mean, a lot of this is, I think, kind of future directed, that we might soon use psychiatry in different ways to really help people flourish. And I found it a little difficult to find current examples of where psychiatry, as opposed to various other kind of psychological techniques, might be used to help people flourish. But one case I thought fit the bill was where psychiatrists had come up with parenting advice that was designed for parents with personality disorders to help them parent more effectively. I thought, oh, that's interesting, because that doesn't really seem to be treating the mental disorder, or at least in a kind of oblique way, but it's just about helping them flourish, helping their children flourish. I thought, oh, that seems like a worthwhile use of psychiatry. I did recently hear a report of, in Australia, a clinical trial of using SSRIs, antidepressants, to help a ex-prison population be less impulsive. And they were hoping if we give these people SSRIs, they're going to be less impulsive, and we're going to get fewer, lower levels of recidivism. Well, that would be great. That would be brilliant when I was being told about this trial, but unfortunately it didn't work. So he built it up as well, and we were all like kind of on the edges of our seats. It's like, tell us what was the result? It was like nothing. But but anyway, something like that would be nice. And all I'm saying is that that kind of goal is what psychiatrists should be pursuing. So, in summary, for the case in support, moral norm following is relevant to both mental disorder and flourishing, and psychiatric interventions can improve patients' abilities to follow moral norms. So it seems that in some cases, moral growth is an appropriate target for psychiatry. So I think that the blanket objection that all psychiatric involvement in patient morality is a misuse of psychiatry seems wrong. So I'm going to set that kind of misuse objection aside, although obviously you might not be satisfied, but I'm going to focus on some of the other objections subsequently. So concerns about limiting psychiatric power, coercion, fiduciary duty, lack of psychiatric moral insight, and risk to the therapeutic relationship. Okay, so how might we resolve this conflict between these apparent reasons against and this, what I think is a fairly strong case in favour of psychiatric involvement in patient morality? Well, we were looking at these arguments for and against, and we thought that it just looks like those people who are against psychiatric involvement in patient morality seem to be worried about psychiatrists shaping the content of patients' moral beliefs, imposing some kind of morality, or imposing an objective view of flourishing that was contrary to perhaps what the patient thought. Whereas those in favour of psychiatric involvement in patient morality tended to focus on facilitating the patient's expression of their own morality or their own conception of flourishing, is to help them live up to their own standards, resolve inconsistencies. I mean, if we think of the example of the jealous father and his violent outbursts, the therapist there doesn't directly challenge the father's belief that his violent outbursts are inconsequential, but takes the established belief that he was badly treated by his own father, and then helps him see the relevance of that for parenting his own son. So then the patient realizes that his violent outbursts harm his son, and he revises his moral beliefs to be more consistent. In the pharmacotherapy examples, this is where drugs are helping people live in accord with their existing moral beliefs. So if you take methadone, it's because it's not always exactly the case, but if you take methadone and you're aiming at recovery, you value recovery, this is helping you achieve the things that you value. Obviously, not everyone who takes methadone necessarily unequivocally values recovery, but there's going to be some cases, at least, where that's true. All right. So I think the case against psychiatric involvement in patient morality more or less dissolves against the procedural approach when you take the procedural approach. At least it doesn't seem as strong. It doesn't seem coercive or contrary to fiduciary duty to help the patient act in accord with their own values. I mean, that seems to be supporting the autonomy of the patient, if anything. Although inconsistency in the patient's moral views sometimes makes it difficult to know what the patient's true moral values are. And in those cases, the procedural approach is to get the patient to confront and resolve those inconsistencies and support the patient in settling on their genuine moral values. So this is consistent with the procedural approach as long as the psychiatrist remains neutral on how the inconsistency is resolved. The second point, treatments remain consented to and in the patient's best interest in this case, so then there doesn't seem to be a problem there. It doesn't rely on any special access to moral truth because you're just using the patient's view on what moral truth is, so it doesn't matter if the psychiatrist has any particular access to moral truth. Obviously, you want them to have abilities to find out what the patient's view of moral truth is. Hopefully that is more within the typical wheelhouse of psychiatry, though, to explore the patient's kind of subjective world. And lastly, it shouldn't undermine the therapeutic relationship because you're not kind of directly challenging the patient's views on this, you're just helping support the expression of their own values. Of course, other kinds of conflict will probably arise. The patient might find it distressing or annoying to resolve inconsistency between moral values or to reflect on their past failures to meet their own moral standards. But if psychiatrists judge that such reflection would be therapeutic, then they can motivate that in a non-oppositional way. You could appeal to the patient's values, for example, their value of being seen as a rational agent capable of moral growth, because someone who is like that would or should reflect on their inconsistencies and their past moral norm breaking in order to try and improve. So we might think if the procedural approach was sufficient, then well, maybe this problem of patient morality in psychiatry is more or less resolved, and this is just a bit of a beat up, really. Like it's not really a problem here. Just take this kind of procedural approach. But I don't think it is quite so straightforward. So the procedural approach seems to be at a loss when patients have a sufficiently distorted or underdeveloped conception of morality. So consider the case of the gang enforcer. So I'm just going to read this out to you. I didn't want to hit you with so much text, but maybe I'll hit you with having to pay attention to me reading. But anyway, here it is. So this is the first of a couple of vignettes, but this is the longer one. So a man who grew up in gangs and used to be an enforcer justifies his past violence by appealing to the gang's code of honor and shows no remorse. Later, in his mid-20s, when undertaking a custodial sentence in prison, he develops a psychotic episode and seriously assaults a fellow inmate. Although he's now left the gang and his psychosis is in remission, he continues to believe that violence is justified to ensure respect. He doesn't believe it is a problem that some people are shown less respect simply because they are unable or unprepared to intimidate others. At psychiatric follow-up from upon release from prison, the psychiatrist is concerned that the patient's moral views increase his risk of violent altercations and further interactions with the criminal justice system, both of which would increase his risk of relapse or another episode of psychosis. Furthermore, if he does relapse, his moral views amplify the risk that he would pose to others. So here, the psychiatrist might begin with the procedural approach and explore the consistency of this patient's moral views. If what the patient says is correct, then the patient himself will be worthy of less respect when he is older and weaker, because he'll be unable to physically intimidate people to gain respect. So this appears to contradict the very high value he seems to place on being respected, given that he's prepared to assault people if they seem to be able to show him respect. But in this case, we can just imagine that the patient resolves this apparent inconsistency by accepting that losing respect is just another downside of aging. So when the patient's moral beliefs are wrong, but internally consistent, or largely internally consistent, I mean, who knows, maybe you could push and push and push and find some kind of failure of internal consistency. So maybe this procedural versus substantive distinction can be put under pressure. But when you can't find internal inconsistency, then the procedural approach is unable to facilitate moral growth. This motivates the substantive approach, where the psychiatrist tries to convince the patient to change the content of their moral beliefs. But here, if you don't try and change the content of the patient's moral beliefs, it seems that they remain vulnerable to relapse, another instance of psychosis. Their flourishing is, they're not going to flourish if they're in prison again. So it looks like you're under some kind of therapeutic pressure to deal with the content of this patient's beliefs. So what might we do? Well, in this case, the goals might be to persuade the patient that violence is a disproportionate way of trying to achieve respect. We might try to convince them that all people are deserving of respect. And I think it'll often be the case that if you're trying to get someone to follow moral norms, then you might also have to be engaged in some process where you can convince them that they can become, or they are, a valued member of society. They might have some investment in a shared moral standard. Now, obviously, this isn't going to be easy, and sometimes it might be impossible, futile in some cases, but sometimes not. So in these cases, I think a substantive approach, in some of these cases, I think a substantive approach is justified, and particularly because procedural approach seems futile. But of course, we want to have some limits on substantive interventions. The substantive interventions appear to bring the moral objections back into play. Seems to be risk of coercion, possible breach of fiduciary duty, the limitations of moral insight seem to be a problem again. We might intuitively agree that the ex-enforcer's morality needs substantive attention, but how can we make a principled distinction between this case and other cases where substantive intervention would be inappropriate? So one way of doing this, I assume it's not the only way, and this is part of like I'm a little bit unsatisfied with this paper, but anyway, I'll just tell you what the idea is. So one way of doing this is, one way of setting a principled threshold for substantive interventions is to appeal to a Rawlsian reasonableness. So roughly, reasonable moral views are those that treat others as free and equal. They ground fair reciprocity, and a reasonable person tolerates different moral views where those moral views are themselves reasonable, and then unreasonable moral views are kind of the opposite of that. Don't treat others as free and equal, ground unfair expectations of social interaction, and don't tolerate other people's reasonable views. So a substantive intervention would be justified if the patient's views are unreasonable, and as long as the intervention remains relevant to psychiatric goals. In the case of the ex-enforcer, the psychiatrist is justifiably concerned that the patient's unreasonable moral views increase the risk of relapse. And an advantage of this reasonableness standard is that it incorporates epistemic humility. Psychiatrist only has to detect and improve moral views that fall below the threshold of reasonability. It doesn't require exceptional moral insight and protects against overzealous interventions, trying to aiming at some kind of moral perfection or something. This obviously demands something of psychiatrists. They need to be able to distinguish unreasonable moral views from reasonable views that they just disagree with. And obviously they need to be aware of when these moral views are relevant to psychiatric goals as well, whether they be boosting flourishing or treating mental disorder. So how does this limited substantive approach fare against the objections. Is fiduciary duty respected? I think there's a little bit of conflict here, depending how you understand fiduciary duty. Obviously, if you think fiduciary duty is just helping the patient support the patient according to that patient's values, then that would seem that you shouldn't challenge those values. But the fiduciary duty of the psychiatrist is presumably to help the patient in the specialist field of psychiatry, mental health, mental illness. And so arguably, it is through following their fiduciary duty that they can challenge some values where those values are undermining the mental health of that patient. So I think there is an understanding of fiduciary duty where it would be acceptable to challenge and try and persuade the patient of views that they don't have at the moment. Is it coercive? Well, in one sense, it doesn't seem coercive at all, because to engage someone in moral argument is to treat them as an autonomous person. It's kind of to take the, Strawson might say, the participant stance towards them and treat them as a morally responsible agent. So in one sense, it seems to be to respect them as a autonomous agent. But I think obviously there is a risk of coercively changing the patient's views. The psychiatrist is seen as an authority, and the psychiatrist could be wielding a lot of power over that patient. So obviously there's a power dynamic that would risk coercion. Another concern is that coercive changes to the patient's moral views, if they can be effected, are unlikely to be particularly effective. It's going to be, you'll have more robust changes to a patient's moral views if they've kind of autonomously come to make that decision themselves. So the psychiatrist should take care to ensure that any substantive moral changes the patient makes have been made autonomously, since that will obviously respect patient autonomy and tend to be more effective. So ultimately we bite the bullet here, though, that there is some kind of risk of coercion if you're engaged in the substantive view. But we think that where the patient has an unreasonable moral view, so these are, not treating other people as free and equal, then this risk is worth taking. So we do bite the bullet there a little bit. And the same is actually true in regards to the therapeutic relationship. So any effort to change the patient's mind about a moral issue obviously has to be broached carefully. The patient might experience a direct challenge to their moral beliefs as a sign of disrespect or coercion. But efforts of persuasion needn't be confrontational. You could find ways to cast an alternative moral position in a good light while appearing to remain neutral. But in any case, I think the risk of damaging the therapeutic relationship is worth it when the patient's unreasonable moral views are themselves a barrier to therapeutic progress. Although if there are other paths to therapeutic progress, you might obviously put the moral stuff on the back burner and approach it later. But where they are as an important barrier to therapeutic progress, then to just refuse to address those moral views would seem to be even more obviously self-defeating than the self-defeating effect that you get if you damage the therapeutic relationship. Okay. And what about underdeveloped moral conceptions? So we were looking at distorted moral conceptions. I think with underdeveloped moral conceptions, we also have an argument for taking a substantive approach. So consider this vignette of a woman with autism. She's struggling to develop close relationships outside her immediate family, but she just doesn't know why. She is talking to a psychiatrist, and she just wants guidance on how to navigate the ethical norms in relationship building. And in therapy, it becomes clear that she is being indifferent to others' interests and doesn't see why she should show interest in things that initially strike her as boring. So here the procedural approach seems to be at a loss because the patient needs some novel content for her conception of morality in these particular spheres. If you take the substantive approach, the psychiatrist can just provide the content that the patient is asking for. It can just inform her that in close relationships there are different moral expectations, perhaps to do with being open to being shaped by the other. And and I think, I mean, does this raise the same similar problems? I mean, helping people elaborate a conception of morality has little risk of coercion and damage to the therapeutic relationship where the patient is requesting that content and isn't committed to a conflicting moral position, I would assume. Of course, it would be wrong to simply indoctrinate the patient with whatever the psychiatrist thinks the moral position is in whatever area. So this process should be as patient-led as possible. But if the moral views the patient gravitates towards in this process become clearly unreasonable, then it would be on the psychiatrist to guide the patient's views back within the bounds of reasonableness. So the psychiatrist should still be grounded by reasonability and psychiatric goals. All right, so some conclusions then. So obviously the first one, psychiatrists should take the procedural approach by default, but escalate to the substantive approach in cases of sufficiently distorted or underdeveloped morality. Hopefully that system can allay concern that psychiatrists might have about involvement in patient morality, because much of it is just going to be procedural, and that seems pretty safe. If psychiatry often works through the implicit facilitation of moral growth, then efficacy should improve if psychiatrists explicitly use this path to mental health. So there should be a payoff in terms of efficacy. And if psychiatry aims at moral growth to achieve mental health, then I'd have an argument for this, but I was stating it at the end. And then it should be transparent about that, I would assume. All right, that's that, and some references. Thanks.
So throughout the workshop, we'll have a short sort of 1 to 2 minute break between the talk itself and the Q&A. Allow the speaker to catch their breath and for you to gather your thoughts, and then we'll do questions in just a moment.
I'll get some more water.
Yeah, go ahead. Okay, so on to Q&A. We'll use a hand finger system. So if you have a substantive question, raise a hand. If you have a follow-up, raise a finger. And if you could just keep your hands up until I've sort of see you and nod at you, and then I'll keep a list. So, any questions? Yeah, let's just start here.
I wasn't expecting to go first, but okay. First, thank you for a really interesting talk. I have a few questions, but I think my main one, maybe to get us started, is about your conception of morality and its relationship to both psychology, psychopathology, psychiatry, and also emotion. So yeah, exactly. So big, broad, but I guess in the broadest brushstrokes, sort of one of, and I'll tell you why this is bothering me, maybe not bothering, maybe it is bothering me. So I'm thinking of, views of morality that are kind of grounded in gut reactions, these kinds of more basic emotional affective responses. And also kind of like the proto-morality of children, where they're making moral judgments and also engaging in moral action, but it certainly isn't, a moral belief or anything sort of as a full-blown state.
Yeah.
And so in some sense, I think, well, what if we're really dealing with these affective reactions that are related to morality in the cases of psychopathology, and not something like, oh, let's argue about what's right and wrong, but really sort of more basic kinds of reactivity. And so, like, how does the view really deal with something?
Right.
Or you do just disagree and say, well, no, that's not the kind of moral belief that I'm dealing with. We're really talking about fully formed, mature beliefs where, the gang enforcer. But I guess I think of that as an outlier, maybe.
I see the problem.
Okay. Yeah, thank you.
I think it's the problem. But Antonella, do you want to?
No, please.
Yes, but what I'm concerned about is moral norm break. So there's someone, and so they might behave in whatever way it was and broken a moral norm that say that people can agree about. They might not know what it was. They may have been driven by some of their moral affective kind of responses. So they might not have any moral beliefs relevant to the norm they've broken, because that's what other people are saying. Oh, you've broken promise to me, something like that. So in that situation, I guess I do see now as somewhat cognitive. I'm seeing the gold standard as being not just effective responses, but to justify and
but in psychology, often not that.
No, exactly. Yeah, and so that would be a reason to bring it to that. In the case of these effective responses, because of course we're all doing it, where those effective responses are regularly leading them to great moral norms, then that's and it's relevant to psychiatry, at least in the sense. Then you're like, okay, those effective responses would perhaps be something that the psychiatrist might hook on to then start the process of like, well, these responses are evangelize the patient. These responses are appropriate in some ways, but it's causing problems in these areas, and then providing the kind of the reasoning behind why you might want to be able to follow these moral norms, or doing various things that are interfering with other people's interests or whatever it is, and that's causing you problems. And so I'm here to help you fix that or something. But maybe I'm not quite getting the core of the question here. Yeah.
And we deal in psychiatry therapy with that, then you'll sort of have more alignment with the moral norms, but without doing anything what you're suggesting, which is engaging in, moral argument or something.
Oh,
like
right.
that.
Sorry.
Right. So that's anything.
Got you. No. So yeah. Sorry. So I've kind of mischaracterized my position by making it seem like I'm going to be too narrow in that regard. That we're going to always, the way to move the sword is always going to be through moral argumentation, not necessarily. Yeah. No. And perhaps quite rarely that would happen. Right. So the process, perhaps. If you look at the example of the jealous father who's just kind of had been unaware or hadn't thought too much about how his violent outbursts were infecting his son, I don't think you go in with that and say, look, everyone's got moral interests, or in kind of bringing some philosophical argument for why he should be interested in his son's well-being, but by making that emotional connection between his experience with his own father, you'd go in that way and not through argumentation. Yeah, but thanks for that. Yeah, because I realised I have actually made it seem as kind of very cognitive, this philosophical endeavour that's going to be going on, but no, I think whatever works is actually going to be what the psychiatrist should use.
Okay, next over here, there's a mic just on the screen.
Hello. There seems to be maybe a weak version of this thesis where the only reason to focus on morality is just insofar as it's going to promote health outcomes. Maybe, we're going to improve this person's morality in the same way that we might encourage somebody to exercise for their heart disease or take their medications for their thyroid condition or something like that. It seems you want to say something stronger and more substantive than that, perhaps. And so I'd like to propose a case to you and see how you might deal with it. It seems, okay, so what if we want to think that there's a case where somebody is too moral, they're overly moral, their morality is overdeveloped. Give it more specificity. Maybe there's somebody with depression. They've already donated their kidney, one of their kidneys. They're constantly trying to be really honest with their friends and just constantly thinking about their morality and ruminating over it and trying to do more good and feeling like they're never living up to that. In that sense, it seems like this overdeveloped morality, this extreme moral rule following might be constitutive of or causally contributing to this depression. And it seems to me the psychiatrist might want to say, okay, you're going a bit too far with your focus on morality, maybe be a bit more selfish. Maybe, you really try to be honest all the time, but, maybe pull that back a little bit. And if that seems to be the right move, then it seems hard to say that we're going to do something stronger than this weak thesis where it's really just in virtue of health outcomes.
Yeah.
Can I just quickly step in? The sound is a little bit dodgy online. I think if we swap seats, it could be better.
Okay. Yeah, thanks for the case. Like that's a really good case to think about. I need to think more about it, but I don't know if I am taking the stronger thesis. I think that's why I'm trying to say, well, we should only be doing this when it's relevant to psychiatric goals, if we can agree on what those psychiatric goals are. Of course, we can expand them quite a bit if we're talking about flourishing, but hypermorality presumably wouldn't be conducive to flourishing. So I am taking, I think, a weaker thesis, but still, I think the case still causes a problem for the way I've presented it, because I haven't kind of made some, what would then motivate the psychiatrist to tone this down? Because why would they just say like, oh, okay, well, you're doing well then. And is that partly because I've got it set up with this threshold of reasonability? I mean, the reasonability standard is very much designed to catch out unreasonable things, at the bottom line. There's no kind of hyper reasonable, someone who's just so suitable for living in a liberal democracy. This is one of the problems about using a Rawlsian standard, which I dislike. Comes in with all this other baggage. So I have to think more about that, because obviously I agree with your intuition that the psychiatrist should be getting this person to tone it down a bit. So yeah, thanks. I'll think more about that.
I think there's a follow-up question just behind the original question.
Hi, thanks very much for the talk. And just a quick follow-up. I had a similar question, I think, about the relationship between morality and flourishing. And I was wondering whether when you talk about this relationship between morality and flourishing, you are mostly discussing, like what you're thinking about is cases like a person achieving his own flourishing by being moral or being too moral to somehow undermine his own flourishing. So that's one option. But what I was thinking is whether when you think about undermining one's flourishing, you also think so what's the problem here? Is that being immoral is inherently problematic for flourishing, or is it that social response to acting immorally is what undermines your flourishing?
Yeah, well, so I'm not totally sure. I mean, definitely, I think both things can be going on, that you can be flourishing not that much because you feel you've failed to live up to your own standards, whether other people know about it or not, right? I think you can feel ashamed of not meeting your own moral standards, even when it's secret, and that could be undermining your own flourishing. But obviously, a lot of relationship with flourishing is how well you get on with other people. So, so I think those are both relevant. Though, I mean, what's the question here? Is the question still like, what, you know, this kind of excess morality undermining flourishing point? Like,
No. So I'll clarify, maybe I didn't get to what I wanted to say, but so let's imagine a person who acts immorally towards colleagues, and they are just rude and aggressive and disrespectful, and everyone suffers from their behavior, but they personally are actually very successful, very content about what they're doing. They don't see any problem with how they behave. And actually the employer also doesn't see any problem with their behavior. So they're being promoted up and up. And the flourishing problem here is whether you think that inherently the immoral behavior is undermining something in the person's well-being, or whether it's just the response. Because if it's the response, then the argument, the discussion goes to a different, I think, direction, which is whether societies should sanction or tolerate immoral behavior. And if it's only about, so that's...
I think if their immoral behavior is relevant to some psychiatric goal, I mean, I'm imagining situations where someone is seeing a psychiatrist, and so maybe in this case, this person's immoral behavior doesn't rise to that level, you know. But if their immoral behavior was undermining their mental health in some sense that was relevant to some kind of psychiatric outcome, then the psychiatrist should get involved. But if, you know, if they were flourishing through their immorality, and then it's like, well, that would be, I think that would be fine, even though I recognize it causes a problem, but I'm avoiding it, I guess. I mean, it's obviously unsatisfying, but but I'm hoping to kind of cut those cases out because they're just not psychiatric cases. Even though, sorry, that's not.
This question sparked lots of interest. There are two quick follow-ups on this. I've also seen someone online has asked, how does one ask a question verbally? So if you use the raise hand function on Zoom, I'll kind of add you to the queue and come to you in due course. So two more follow-ups on this question, and then we'll move on to another substantive. So Jim first, and then just to say everyone's like on the around.
Hi, thank you. So this does dovetail onto the previous question, I think. How is the psychiatrist, you know, supposed to differentiate between unreasonable moral views and reasonable views that are considered immoral? I think you had one of your sentences up there. It seems slippery and difficult for the psychiatrist to decide that, and maybe needs more definition.
Yeah, I mean, this is partly why this kind of gets towards the part of the paper that I'm unsatisfied with. I didn't really like reaching for a rule. I think you could reach for some kind of idea of reasonability. There's this Rawlsian reasonability. I mean, if this was to happen, it would require, you would want training about it, like to try and work out what's unreasonable and what's reasonable by this standard. Or even if we don't choose that standard, if you're going to use the substantive approach, I assume we're going to have to appeal to some threshold. And if a psychiatrist is going to be trying to apply that threshold, then they need to know where it is, and that should be consistent. And so you would want to be trained to know what that was, and you'd probably also want some kind of professional interaction where you could kind of double check with other people as to how, you know, I've got a patient that's behaving like this and saying things like that. Do you think this counts as unreasonable? And you could kind of, you know, get some kind of professional feedback. But the Rawlsian idea is that you're treating other people as free and equal is one of the core aspects of what it is to be reasonable. And to be honest, I'm not a Rawlsian scholar, but you've got the burdens of judgment, and everyone's laboring under the burdens of judgment, and the burdens of judgment of why we come to different conclusions despite apparently living in the same world and so on. And so an unreasonable view is generally quite an out there view and should kind of stand out. At least that's the hope. I mean, if the system would work, that would be the hope. But wherever you set a threshold like this, you're going to get a threshold problem, and that's, I mean, I don't. One reason I don't like this is maybe because I don't love this way of setting the threshold. So that's why I say one way of setting the threshold for where the substantive approach would kick in would be this. I subsequently feel like actually I'd use a different approach, and I'd say I will throw out this idea of reasonability, and I'd just say no, it's up to the psychiatrist to make a judgment to do as much moral work as they thought was relevant to the psychiatric situation, and that would kind of kill two birds with one stone, and that would kind of create a natural limit on how involved the psychiatrist got involved in morality. And it would of course always mean then that getting involved in morality was relevant to psychiatry, which I've got as two different pieces. But anyway.
Yeah, one last follow-up to say.
Thank you for a talk. I would like to ask you two questions. I have the impression that all the question you try to answer by this hesitation between the procedural or the substantive approach, it derivates from two suppositions that for me they are not clear. First of all, I think, if I understand well, you have a supposition that moral duty is necessarily applicable to psychiatric patients the same way it is to anybody. This is the first assumption.
That we should expect patients to meet the same moral standards or moral duties as anyone. Do you mean, is that what the...
Yeah, I mean, in two senses. First of all, is it so that moral duties are absolute at a point which even a person suffering for some disorders necessarily have to judge that he is obligated to these duties? And secondly, even if you say so, isn't it so that in therapeutic relationship, maybe it's like an island apart from the world where moral duties apply? I mean, because we can assume that for a patient that comes to see a psychiatrist or any mental health practitioner, all other instances around him are all the time pushing him to apply moral duties and to observe them, etc., etc. Is it even if you say so that moral duties are applicable the same way to these people as they are for everybody, maybe it's not the place to apply them in a therapeutic relationship.
Yeah,
Well,
thanks.
those are those two questions.
Yeah. No, so, well, one thing I might say is, I mean, I tried quite a lot to just talk about moral norm breaking rather than moral failures or being morally responsible for actions. So it's just, being blameworthy, say, for something you've done. So I'm not even, I don't want to commit to the idea that, if someone has broken some moral norms while they were psychotic, I mean, we just wouldn't say that they're morally responsible. In many cases, we wouldn't say they're morally responsible for that. Then when they get, so in therapy, I definitely don't think it's the case that the psychiatrist should be holding them morally responsible. I know this is not exactly what you were saying, but it shouldn't be holding them morally responsible for what they did. Should, and I do think that there's some room to relax some moral standards in the clinic. So maybe this could be a friendlier environment, if you like, where you're not being held to quite the same moral standards, although you obviously are being held to moral standards. I mean, a psychiatrist, you wouldn't want to be a psychiatrist if moral standards didn't, any moral standards didn't kind of obtain in the clinic. It's going to be it's like not a good place to be. So I'd want to say that this could be like a generous space where you're not going to be blamed, but if this disposition, moral norm breaking behavior is undermining mental health and or flourishing, then it's the job partly of the psychiatrist to help get the person up to typical moral norm following speed when they're outside the clinic. I mean, hopefully that's not going to happen straight away. So I'd say it's a process of helping someone along in that development. So you could do that gently without kind of in this room, all kind of top moral standards apply, and so you wouldn't have to say that. So does that kind of answer your question? So I don't think that in some sense full moral duties are kind of required of the patient, I guess I'd say. But they ultimately will be.
Yeah, actually,
in the interest of time, if you want to move on to the next.
We'll talk after.
so actually, what I'm saying is not that moral breaking should be tolerated, but rather, can we talk about moral breaking in this context? You understand what I mean?
We'll chat about it later.
It's different to say.
I'm going to move on to the next question, and there's plenty of time to continue this conversation. So the second row.
Thank you very much. I just have one question of information before I just ask my question. In America, psychiatrists are sort of the sole mental health providers who can give out psychiatric meds. Is that also true in UK?
I'm not totally sure. I think it's not 100%, but then I don't know. Rivka, you seem to.
Okay, I just needed to know. You'll see why it was relevant. So I have two comments and then one question I want to ask about. So the first comment is I just accept, I think, what the Pearson-Pickard paper that you referred to at the beginning, and also your general line. It seems to me just a general feature of certain professions that they're normative. And I would include in that, teaching, social work, being a minister of God, clergy members. It just seems to be the case, and all that certain professions we know in advance. It's sort of like truth in advertising, just in virtue of being in that profession, that the person is going to sort of be working with you, the other, in a normative way. So that's just a general observation. There's then the question about the quality of the normative interaction. So I just take it sometimes in all these cases, you'll be called upon to correct a person epistemically or morally, as you say. Now, one reason I'm not a mental health worker is because probably my techniques are terrible. Like if someone is racist or sexist, I just tell them and they say, stop that. So I understand that mental health workers can't do that. Or if someone has just false beliefs, one just can't do that. But I understand the general line of argument. But that's an observation. The second observation is that I would just not use, but this is just a suggestion, the concept of moral development in your work. And one reason for that is simply inside psychology, the history of psychology. We have, starting in Piaget's work in 1938, the moral development of the child, and then Kohlberg's work in America. He passed away in the 70s, but it's still a very active research program, especially in education, not in psychology. And for the young people in the room who don't know this, there was a theory that moral development proceeded in roughly the way that Piaget said logical and cognitive development proceeded. And the idea was that if you're at stage 3, you're what Kohlberg would call a bag of virtues. That's an Aristotelian or a Platonic view. Stage 4 is a social contract view of morality. Stage 5 was utilitarianism, and stage 6 was Kantianism. Now, if a theory like that were true, then psychiatrists and everybody else would have a different kind of problem, right? We'd be bringing people up this sort of scale out of Plato's cave into
Kantianism, yeah.
So, but that view has just been completely undermined. So that's just a suggestion. But then my question goes like this. So going back to just the first observation about normativity, all these are normative disciplines. So I'm going to give you a particular example that I faced recently. So I have, and it has to do with psychiatric care. So I head a Center for Comparative Philosophy in the United States, and I have a lot of students from East and South Asia. And over the past couple of years, my Chinese students, usually late 20s, early 30s, especially during COVID, have had a series of problems related to a virtue, a major virtue in Chinese tradition called Shao, means filial piety or family loyalty. Now, this generation of students are all singletons. They know what siblings are. They just have none of them. So they have tremendous responsibility. So I, being a nice professor, tell them to go see a counselor. And if they go see psychotherapists, they tell them, well, one technique you could try is to try to be more like Americans, indifferent to the elders. So that's a way of helping them. But what typically happens if they go see a psychiatrist is they're immediately given an SSRI because they show some symptoms of depression, or an SSRI because they show some symptoms of anxiety, or a benzo because they have some symptoms of anxiety, or in some cases they're given Adderall because their attention keeps wandering to their parents and off their work. So I think one of the things that we'd really need to do, at least if
Could you ask a question so that
that is my question, what would one do about this sort of training of psychiatrists, given this sort of tendency to treat this is in a multicultural world, this is a big problem. And then the treating of symptoms as opposed to helping with the moral issue. That's what I was trying to do by the example. Thank you.
Yeah, I mean, the point on moral development is taken. I actually been trying to take that out, and I was switching in for moral growth, which I maybe also don't love, but I was hoping to avoid I haven't obviously completely managed it. Yeah, I mean, that example is fascinating and just goes to show how complicated really this is. It's not like, oh, the patients are racist, I'm going to have to like stop them being racist. I mean, and obviously, I don't like the sound of pharmacotherapies for this stuff. And I mean, this has been a problem in psychiatry for a long time, that there's been a kind of pharmacotherapy bias towards how to fix problems. And this, certainly doesn't strike me as the right way to approach this. But it does, certainly in the paper, we do say a little bit about what this would mean for like how psychiatrists might help to achieve moral growth, or even maybe not even growth is the word, but settling upon or thinking about your own moral normative commitments or whatever that is, even if they're not, they're not wrong, but they might be, you might want to change them for various reasons. And it's not enough words in the paper because it's a really short paper, but you might want to train psychiatrists in knowing some normative theories of philosophy, but that's not going to do a huge amount for most people, right? I mean, so they're not going to they're not going to be convinced by hearing about Kant that they shouldn't be racist, for example. So yeah, I mean, you would want more techniques of being well read in different literatures, being aware of different cultures. I mean, in this particular case, you'd want need a psychiatrist that has an understanding of the cultural background, a deep understanding of the cultural background of these people. You can't just read a bit about what's going on in China and think, oh, well, I know how these kids are feeling now, and now I know how to help them. I mean, it's just not going to be enough. So I mean, this is not totally satisfying, but thanks for the example is helpful to think about. It's actually really complicated.
There are more questions in the queue, but I'm afraid we're out of time. So apologies if we didn't get to. All that's left now is to thank our speaker, Dr. McConnell, for a really fascinating talk.